Good afternoon, ladies and gentlemen. My name is Nirav Shah, and I am the Director of the State of Maine Center for Disease Control and Prevention. And I'm here today to join everyone to provide an update on the COVID-19 situation across the state. And unfortunately, we again begin today's briefing on a sad note. Maine CDC is reporting an additional death, the passing of a woman in her 70s from Waldo County. This unfortunately marks the 35th death of a Maine person with COVID-19 on a day in which overall in the United States there have been over 40,000 deaths. We at Maine CDC offer our condolences to the family of this woman during this time of their grieving. In addition, Maine CDC is reporting now 875 total cases of COVID-19, an increase of 8 since yesterday. As of this morning, there have been no additional cases recorded at long-term care facilities since yesterday. Presently, there are 138 individuals who have been hospitalized at some point during their COVID-19 illness, an increase of 2 since yesterday. And overall, 414 individuals have recovered, which is an increase of 62 since Friday. Maine CDC continues to work with 5 long-term care and assisted living facilities across the state as they grapple with outbreaks of COVID-19. Just to provide a quick summary of where those stand. At the Augusta Center for Health and Rehabilitation, there are now a total of 73 cases and individuals affiliated with that location. That comprises 47 residents and 26 staff. Sadly, there have been 3 deaths associated with that outbreak. At the long-term care facility in Falmouth, there have been now a total of 14 cases, 7 among residents and 7 among staff. At the Maine Veterans Home in Scarborough, there are now a total of 47 cases, 30 among residents and 17 among staff. At the Tall Pines facility in Waldo County, there remains 38 cases in total, 28 residents, 10 staff, and sadly 8 individuals who have passed away. And finally, at the Cedars, an assisted living facility in Portland, there are a total of 10 cases, 7 among residents, 3 among staff. Overall, statewide, there are 119 residents affiliated with long-term care and assisted living facilities where outbreaks are currently occurring of COVID-19. Also, there are 63 staff for a total of 182 individuals affiliated in some fashion with long-term care facilities. In terms of the number of individuals who are currently hospitalized, hospitals in Maine have reported to Maine CDC that as of this morning, there are 16 individuals in Maine who are currently in intensive care units, and 23 individuals in Maine who are in non-intensive care unit hospital beds, for a total number of hospitalized of 39. Overall, 9 Maine people remain on ventilators related to their COVID-19 status. I'd like to turn next to an update on where things stand with personal protective equipment. Today, Maine CDC is picking, packing, and delivering 62 orders of PPE to healthcare facilities across the state. Our principal area of focus remains long-term care facilities and assisted living facilities, given the outbreaks that we've seen, as well as the possibility for additional outbreaks at other parts of the state. In terms of our overall inventory, right now, Maine CDC has in its inventory approximately 199,000 N95 masks, 126,000 regular surgical masks, just under 4,000 face shields, approximately 19,000 gloves, just over 3,000 disposable protective suits, and about 7,400 surgical gowns. One of the aspects of PPE that we talk about a lot are the N95 masks. These N95 masks, or N95 respirators, as they're often called, are highly specialized, intensely designed masks that can filter out the virus, whether it's coronavirus or many other viruses. But in order for those masks to be used to their optimum performance, an individual has to go through what is called fit testing. This is a process whereby the mask is fitted to their face and some sort of bitter tasting spray is sprayed. And if the individual can taste or detect that spray, we know that the fit of the mask is not appropriate and the fit has to be adjusted. This fit testing process is essential for any individual who wishes to use an N95 mask, because as you can imagine, if the mask isn't appropriately fitted to the face and there's not an airtight seal, that's evidence that the virus can sneak through and still cause an infection. So for weeks now, one of our goals has not just been to deliver more N95 masks, but also expand the number of healthcare workers who have gone through this fit testing process so that they too can take advantage of the N95 masks. Today, I'm pleased to report that working in concert with our colleagues at the National Guard, there will be an additional 22 individual men and women from the Guard who are certified in the process of conducting this fit testing, who will be quickly deployed across the state to different locations to help healthcare workers get fit tested, to go through that process to ensure that any mask they get has an airtight seal and is actually capable of protecting them against the virus. So I'd like to take a minute to thank the men and women of the National Guard for joining us in that work to help expand the number of healthcare workers across the state who can utilize these N95 masks. This effort to expand fit testing comes on top of very intense work that is already being done by two other groups I'd like to take a moment to thank. The first are county emergency management associations. Each county in Maine has an EMA, an emergency management association. And for weeks now, those counties have been going across their respective areas to offer fit testing to healthcare workers. In addition to that, fire departments across the state and fire chiefs have also been offering this fit testing. With the addition of additional members from the National Guard, we're hoping that as many healthcare workers as possible can get fit tested and take advantage of N95 masks in order to allow them to continue staying safe on the front line. And so I'd just like to take a second to thank the men and women of the National Guard, the men and women at the county emergency management agencies, and the men and women in fire departments across the state for helping us get folks fit tested. I'd like to finally conclude with a quick update on where things stand with vital resources across the state. In terms of the number of available ICUs, in total, there are 316 ICU beds, 152 of which are available. There are 336 traditional ventilators, 287 of which are available. And finally, hospitals report to us that there are 369 available alternative ventilators on top of the traditional ventilators we also have. So with that, I'd like to turn things over, or before we turn to the media, just one last note. There have been a lot of changes with respect to the way the complexion of the outbreak across the state of Maine, across the country looks. And the bottom line here, folks, is that we're still in the middle of things. And so I urge everyone to continue with the social and physical distancing measures as long as we need so that we can keep everyone in the state safe. Again, I urge everyone to continue with those physical distancing measures because we are still very much in the middle of things. So with that, I'd like to turn things over to our colleagues in the media. And our first question today goes to Rachel Mann from ABC7. Go ahead, Rachel.
Hi, would you be able to tell us how many of the confirmed cases are healthcare workers?
Rachel's question is, of the confirmed cases, how many are healthcare workers? And Rachel, as of this morning, that number is 212 of the confirmed cases are healthcare workers. Next question goes to Charlie from the BDN. Go ahead, Charlie.
Yes, thank you, Dr. Shah. I have a question about the universal testing that's prompted at long-term care facilities when there's an outbreak of COVID-19 there. Do those offers extend to agency staff from outside agencies who have been working at the long-term care facilities in the days leading up to an outbreak, but potentially then may have gone on to other facilities after that?
Great question, Charlie. Charlie's question is, when we engage in universal testing or offer universal testing at long-term care facilities with an outbreak, do we also offer that testing to agency staff members who may only be at the facility on an occasional basis? Charlie, I'm going to triple check, but the answer is yes. And the reason I'm going to triple check is that what we know about staff that you describe is that they're not often at the facility each and every day. And so if a staff member, say a therapist, is only at the facility 1 day per week, what I'm going to check on is how we reach out to that individual and whether it is the long-term care facility or the agency that reaches out to that individual. But the bottom line answer to your question is yes. We view anyone associated with that facility as potentially being involved in the outbreak, either being at risk for it or having the potential to spread it. So we want to cast as broad a net as possible to try to do as much testing as we can in those situations. So thanks for that question, Charlie. We'll turn next to Brad Rogers at WGME.
Thanks, Dr. Shah. You know, we've got about 40% of the cases I would roughly say are healthcare workers and people in congregate settings. The numbers would actually be a lot lower without that group. I'm just wondering, it seems like most Mainers are being responsible. Otherwise, we would have much higher numbers. Is it possible to start to reopen the government and just ask people to continue being responsible, wearing masks, and keeping physical distancing and washing their hands and things like that? Is it possible to do that and not see the numbers jump up?
So Brad raises the question about, given that roughly 40%, and I'll get you the exact tally in just a second, Brad, but given that we have a high number of cases that are accounted for by healthcare workers as well as our friends and family members in long-term care settings, is there a strategy under which we could start to reopen the economy given those percentages? So first, the numbers, Brad. In total, there are, as I mentioned, 212 healthcare workers and 119 residents of long-term care facilities, and that accounts to 38.6% of all of our cases that are accounted for by those two groups. So, Brad, you know, I understand, and I certainly have been thinking about the question you raise, but the concern here is opening up too quickly. There has been the experience in other countries around the world where they have opened up too quickly and inevitably have seen a second spike in cases. Most notably, that's happened in Singapore, but they are hardly alone in making that. And so I think even though the numbers you point to are intriguing, we really have to think hard about how we feed that into our calculus in terms of how to open back up. because although there are risks on both sides, if we open up too early, the risk of a secondary bump in cases is pronounced. It's sort of a sliding scale. And if we get the scale incorrect, then we have this risk of a secondary bump in cases. So I think we have to approach it with caution. We're taking a look at the exact numbers in the way that you noted, Brad, but just to give you what's going through our minds and how I think about this is always with the view toward that risk of having a secondary bump in cases, which would again disproportionately fall upon healthcare workers and long-term care people, folks in long-term care facilities. So we've got to take that into account. The folks we're trying to keep safe here are the very people who could bear the brunt of any secondary spike in cases. I'd like to turn next to Kara DeRose at the Maine Beacon.
Thank you. So a few weeks ago, the Mills administration issued an executive order restricting non-essential healthcare personnel from long-term care facilities. I've talked to some workers at different facilities who seem to have interpreted this differently. Can you clarify which healthcare personnel qualify as essential workers?
Sure. So Kara's question is about when it comes to healthcare workers, what is deemed to be essential? And by implication, what is deemed to be non-essential? The lists here get pretty long and pretty exhaustive. And so I won't run through all of them. But what I would recommend there, Kara, is that for any healthcare worker who's not sure whether the service that they provide is truly essential, the best thing to do is to reach out to somebody in the administration, be that DECD or the Maine CDC or the Maine Department of Health and Human Services generally, to get clarification. Even folks who may feel that their job is essential on a day-to-day basis, it may not be. And the exact opposite may be true as well. There are some folks who feel that they may, for some days, be in the non-essential category, but if a patient's really ill or a patient has unique circumstances, they may be deemed to be essential. So there is a case-by-case component of it as well that necessarily recognizes the different clinical conditions of each and every patient. That's why we've tried to take more of a flexible approach rather than a bright line approach, because what's essential for one patient may be non-essential for another. But thank you for that question. It's certainly one we've fielded, and I certainly understand where it comes from. I'd like to turn next to Amy Brown at WERU.
Thank you, Dr. Shah. The death rate in Waldo County is very high compared to the number of cases, much higher than anywhere else in the state, with 8 deaths with 43 confirmed cases. Even given that other counties have, with Tall Pines being in the county, there are other counties that have long-term care facilities with outbreaks. It still seems very high. Is there any reason for that, or is that just a fluke? And then also, could you say anything about whether or not there have been home deaths and how that's being monitored and tracked?
Okay, so Amy raises 2 questions. The first is about Waldo County. And given the presence of the Tall Pines facility in Waldo County, what can we say about that? And is it an anomaly in some way? And, Amy, the answer there is that outbreaks in facilities we know are pernicious. And it's very difficult to know at the time, or even sometimes in retrospect, why certain outbreaks in some facilities took hold and other outbreaks in other facilities didn't and were contained. There are so many different factors that go into determining how and under what conditions an outbreak will actually take hold and lead to exponential growth, or in some cases, a high number of fatalities, as sadly we've seen in the Tall Pines facility. And there really are just too many factors to enumerate. The easy instinct, of course, is just to say, did the facility do something that they shouldn't have? And really where we are right now with Tall Pines, our investigation is underway. So that's certainly not our position. We still need to gather more facts. And please rest assured that we have discussions with the facility, our team does, on a very frequent basis to make sure that their needs for PPE are being met, their needs for staffing are being met, their needs for technical assistance are being met. But it's difficult to draw a straight line or any sort of line between any constellation of factors and any type of outbreak, given the different patient populations, their preferences, so many other factors that go into things. So that's, I hear where you're coming from, but at this stage in the investigation, we just really don't have anything more to say about any type of causal element. You also asked about deaths in individuals that occur at home. And if those individuals happen to have or carry a COVID-19 diagnosis, then they are labeled as an individual who passed away with COVID-19. But in any outbreak situation, in fact, in any infectious disease situation, we also know that there are folks who may not have received a positive diagnosis, who may, for example, be in hospice care, who prefer to pass away at home on their own terms, under their own circumstances, with their own family there. It's not common practice to test those folks after the fact, although the medical examiner's office does have the ability to do so. Generally speaking, it's not standard practice for any infectious disease, but again, the medical examiner does have the ability to do so as they see fit. I will turn next to Kate Koff at the Ellsworth American.
Thank you, Dr. Shah. I am wondering, I know there are probably limits on the answer to this question because of HIPAA compliance, but can you talk broadly about what kind of presentations you're seeing in patients who've been hospitalized? I mean, obviously we're all aware of respiratory issues, but are you seeing any renal issues or cardiac problems? I'm kind of wondering in particular about dialysis and whether or not we have any hospitalized patients who are on dialysis related to coronavirus.
Great. So, Kate, I want to make sure I'm clear and I answer your question concisely. You're specifically asking about hospitalized patients and their clinical presentations, right?
Correct.
Okay. So, Kate, what we've seen among hospitalized patients are a few things. They tend to skew a bit older. Their symptoms do tend to be predominantly respiratory, as opposed to non-hospitalized patients and severely respiratory, so extreme shortness of breath, oxygen levels that are very low, as opposed to non-hospitalized patients for whom the most common symptoms have tended to be body aches, sore throat, a bit of fever, and a mild cough. Among those who are hospitalized, the most common symptoms are a very deep cough, very low low what's called oxygen saturation, and pretty severe shortness of breath. And that's typically the criteria under which doctors make the decision to hospitalize somebody. Now, Kate, you also asked about dialysis patients. I don't have our total number of hospitalized patients who have received dialysis, or the corollary number, which is the number of total cases who are also individuals receiving dialysis. I can see if we can try to track that down and get that for you, but I don't have those numbers with me right now. We do know, however, to wrap up, that according to some data that the US CDC put out a few weeks ago in their main journal, individuals on dialysis are considered to be a high-risk group. And that was a bit of an interesting finding. We anticipated and expected folks with lung disease certainly to be in a high-risk group, but it was also individuals who are on dialysis. So we've been working with and providing guidance to dialysis facilities to make sure that patients can continue to receive dialysis and be at as low a risk as possible for COVID-19. I'm going to turn next to Megan from WMTW.
Hi, Dr. Shah. Thank you for taking my question. It is in relation to how many Mainers do you think are currently and still abiding by the stay-at-home guidelines? Anecdotally, there's a lot of people on the streets and a lot of people in cars. I know you guys were tracking some cell phone data at some point, which indicated that we had a drop in traffic rates. So I just didn't know if there was anything that pointed to Mainers really still heeding that advice. I feel as though the second you talk about opening up the government again, everybody kind of gets itchy to get out.
Sure. So Megan's question is about whether we have any updated data on the way that Maine people have been abiding the governor's recommendations and executive orders to stay inside, stay healthy, stay at home. And Megan, the data that we've seen, as you're aware, we typically look at different types of data. Some of it are cell phone data that are publicly available and collected by the cell phone companies, not by the state, as well as traffic data. And we haven't seen any significant changes. I'll take another look at the data myself, and if that's changed, we'll get that for you, Megan. But the other piece of data that we've started looking at more seriously is not just the number of people who have traveled or the number of coronavirus cases themselves, but we're also looking at the number of people who go or call their doctor reporting symptoms of the flu. And what's been interesting in Maine as well as across the nation is that over the past several weeks, the number of individuals across the country and in Maine who have reported any sort of flu-like illness has gone down quite significantly. We can get you these data as well, Megan. They're also available online in our weekly flu report that one of our flu epidemiologists continues to publish, despite also doing another full-time job as a full-time COVID investigator. But what those data suggest is that by staying inside and abiding Governor Mills's recommendations and rules, we've not only gotten a hold of COVID-19, but we've also dropped the number of influenza cases as well. So there are these other positive benefits to folks having stayed inside in addition to COVID-19. And Megan, and for everyone, those data are available on our website. We publish a weekly influenza report. And again, I would be remiss if I didn't call out the fact that the woman who is the epidemiologist, who is a full-time flu epidemiologist, is now doing a separate full-time job as a COVID investigator epidemiologist as well. But she hasn't missed a beat with her flu reports. They still come out every single Tuesday. And that's something that I wanted to just draw attention to and thank her for. So Megan, if you can't find those data, we can certainly get them for you. I'd like to turn next to Pat Callahan at News Center. Hey, Pat, your line is open, sir. All right, we'll check back in with Pat in just a moment while we turn to Michael Fern at the Maine Edge.
Thank you, Dr. Shah. I have two questions. Since we shut down the economy to slow, of course, the spread and flatten the curve, and the vaccine is probably a year away, have the goalposts moved regarding the curve that may lead the administration to extend the shutdown much further than anticipated? Governor Mills said Friday the key was to defeat the virus, but if we wait too long, don't we risk greater economic and sociological harm? And my second question is, when we do start to reopen, will that curve data determine whether it's going to be a county-by-county approach or a sector-by-sector? Thank you.
Okay. So thank you for those questions, Michael. Let me take the first one. And you framed it in terms of what are the goalposts. And I think that's the appropriate metaphor in many respects, partly because in the White House plan, they themselves talk about just the gates that we would need to pass through at different stages. And so what I think is implicit there, Michael, is that it's a multi-phase process. Again, there's not a single switch on the wall that will determine when the economy is back open. I think of it a bit more perhaps as a dimmer switch. And we will be continually adjusting the dimmer switch to adjust or provide the amount of light that we need for different types of rooms. And if we take a look at the White House criteria themselves, I think those lay out the initial set of goalposts that we need to hurdle over. Gosh, I'm mixing every metaphor now. The initial set of criteria that we need to get to before we can start moving through the phases. And the White House talks about a downward trajectory in influenza-like illnesses and a downward trajectory in COVID cases. They also talk about a downward trajectory in the confirmed number of cases, as well as making sure hospitals can care for high numbers of patients, as well as provide for the safety. Those goalposts haven't really moved, and those are the ones we're abiding. Now, you ask similarly about a county-by-county versus a sector-by-sector approach. And I don't think those two approaches are mutually exclusive. I think there's still a lot of discussion going on, but it's likely to be a matrix where different sectors may be viewed somewhat differently in different counties. Similarly, different counties may have different timelines based on the sectors they have. So I don't see those two circles of the Venn diagram being mutually exclusive at all. In my head, I think of it much more like a matrix. I'd like to turn back to Pat Callahan. Pat, are you with us? All right, we'll try Pat back in a moment. I'd like to turn next to Patty White at Maine Public. Go ahead, Patty.
Double or triple the testing capacity, which would mean several millions of tests per week. And I'm curious what those numbers look like in Maine. And I'm also wondering if you can give us an update on testing capacity in terms of the rapid tests, the antibody tests that you mentioned last week that the CDC is researching, and also commercial labs. Some commercial labs are saying that they now have excess capacity. And I'm wondering if that's something that Maine is able to tap into.
Great. Patty, I'm going to tackle your two questions about testing and then ask you to repeat the first one because I didn't get all of that. So let me first provide an update on where things stand with the rapid testing. As we've discussed at these meetings, the state of Maine received 15 of the rapid Abbott ID Now platforms. And although we were initially told by the U.S. government we would be receiving 100 test kits, we only actually got 5. Thanks to a generous donation from our colleagues at Martins Point Healthcare, they added to our 5 by donating 10 more, which gives the state a total capacity of 15 test kits. Each test kit can provide approximately 23 tests each. So right now, those platforms are being deployed across the state. We're focusing right now on healthcare centers in the state that care for individuals that are at a high potential loss to follow-up. So healthcare centers that take care, for example, of people experiencing homelessness, who, if they test positive and immediate clinical measures and immediate public health measures are not taken, it may be a while before we see them. So we focused our efforts initially on facilities like Greater Portland Health, as well as PCHC in Bangor, given what we know to be concerns about outbreaks among people experiencing homelessness. The second phase of the distribution will focus on hospital emergency departments, particularly in the highest prevalence areas. The theory underlying use in hospital emergency departments is one that we will be able to use to save PPE. But given the small number of test kits, we've also ordered more test kits from the federal government. We haven't received them yet. And so as soon as we do, we're hoping to be able to scale up testing a lot more using these Abbott platforms. Patty, your other question was about commercial laboratories. I don't have the numbers right now in terms of the number of tests that they are conducting. We usually tabulate those on Wednesdays, and so I haven't seen the latest results this week thus far. But we have been told anecdotally only that the turnaround time for those commercial laboratories has been several days. Some providers have indicated to us upwards of 5 days. And so that's one of the reasons that we at our laboratory in Augusta are hoping to scale up our capacity, which is to say to try to provide a faster turnaround time. Our lab has a turnaround time of about 24 hours as opposed to several days. And I suspect that was the thrust of your first question, but could I ask you to repeat that, please?
Yeah, sure. So Dr. Fauci has said in order to reopen states, that basically the U.S. across the board needs to double or triple its testing capacity, which I think his estimate was, several millions of tests per week would need to be conducted. And I'm just curious, what do those numbers look like in Maine? Like how many tests would we need to be able to do in Maine every week?
Great. Patty asks about the total testing capacity that we might need in order to hit Dr. Fauci's mark of doubling or tripling our overall test capacity. And Patty, we were actually huddling this morning. Our lab and epidemiology team were to try to get a better sense of those numbers ourselves. Again, I want to draw a distinction here between the amount of testing done and the amount of testing capacity. The amount of testing that is done is driven largely by physicians. and their clinical judgment as to whether a particular patient needs to be tested at all. The amount of testing capacity is what the state can help with. One of our goals at the laboratory in Augusta is to ramp up that testing capacity just for the state laboratory to be on the order of several thousand per week. Now, we may not do that many. That's driven by physicians and their clinical need. But our goal overall is to be at a place where every physician in Maine is able to test every patient she or he sees fit without having to worry about resource constraints. So some of that will entail working with commercial laboratories to see what their available capacity is, and then an equal part of it will entail beefing up our capacity. But to this day, the constraint on that capacity remains the availability of reagents at the federal level. That really is the constraint, and specifically the extractors that we use. That has been and continues to be one of the greater constraints on, at least at the state level, expanding lab capacity. I'd like to turn next to Brian Sullivan at WABI.
Thank you, Dr. Shah. Can you talk a little bit about Stillwater Health here in Bangor? We received a report that a staff member there tested positive. And can you clarify, if that is the case, when universal testing is enacted, if it's compared to a resident or a staff member who may come and go more freely? Is it a third positive test, or is it once you get to that fourth positive test that the universal testing is enacted? It's
okay, great. So Brian, the answer to your latter question is that when you get to that third test. So an outbreak, that's the classical definition of an outbreak or a trend, whatever label we attach. It's 2 or more cases that are connected epidemiologically. And so whether that be a staff member, whether that is a resident, that is the threshold at which we recommend and offer universal testing. Staff members and residents may decline, as we've seen in some instances, but that's the point at which we recommend the facility pursue universal testing. Some facilities have pursued universal testing on their own with commercial laboratories. Other facilities have chosen to use our laboratory in Augusta, but that's the definition of an outbreak, and that's what we've seen other states now follow Maine's lead in terms of when to offer universal testing. Now, with respect to Stillwater, can't comment on that right now. There's still a lot of data that we're gathering, so we'll be able to have more for you very shortly there. I'd like to turn next to Kevin Miller at the Press Herald.
Yeah, hi, Dr. Shah. I had a question about testing that Patty asked that already. So one question that I have is when we're all out circulating, you see some people wearing masks, some people not wearing masks. Go to the grocery store, it's a mix of folks. Obviously, there's the official recommendations from the U.S. CDC. Can you just give me your thoughts on when it's appropriate, when it's not appropriate, and for instance, when you go out in public, do you wear a mask? And I'd love to get your thoughts on that.
Sure. So Kevin's question is about masks and and our thoughts with respect to when to wear them, when it's appropriate. And Kevin, I don't want to be nitpicky, but I do want to start on a terminology note. I think what your question is really talking about, Kevin, and you tell me if I'm wrong, is not so much masks but face coverings. Is that correct?
Yeah, exactly.
Okay.
Cloth, or some people look like surgical masks. A lot of people wearing the homemade cloth masks.
Great. And so I do want to, good, thanks. I just wanted to make sure I answer your question directly, Kevin. There is a distinction between face coverings and face masks. A face covering is something that you yourself can fashion at home out of some fabric and some rubber bands. There are numerous videos on how to do so and how to take care of that face covering. A face mask is what we talk about when we talk about a surgical mask or an N95 respirator. Those are typically reserved for, and should still be reserved for, healthcare workers. But face coverings, the U.S. CDC released guidance that recommends that when individuals are in places where physical distancing is not possible, they wear a face covering. And Kevin, I think that guidance is worth heeding. I haven't really been out in a public setting of that sort in a while, so I haven't had the need to wear one. But what my family members do when they have to make a run to a grocery store, if they have to make a run to a grocery store, and we've tried to limit that as much as possible. They put on a face covering of that sort. What the face covering does is, as we've talked about, it doesn't protect you so much from other people, it protects other people from you and any virus that you might transmit. So in that regard, there are some data to suggest that these cloth face coverings can reduce the spread or transmission by some amount. And that's a good thing. At this point, without a vaccine, we should take every advantage that we can get. But as everyone goes about wearing those, and I've seen folks wearing them outside, and I think that's great, I would just urge everyone to bear in mind that they are not substitutes. They are not substitutes for physical distancing. And they should, and by wearing one, it does not mean that you can crowd somebody in line or avoid the other physical distancing requirements and recommendations that are out there. So, but I'm glad you raised that, Kevin. And I'd like to, let's see, next question goes to Patrick Whittle from the Associated Press.
Yes. Hello, Dr. Shah. Thank you very much. I wanted to piggyback on what Patty White was asking about earlier when we were talking about testing capacity. We all know that testing capacity is very important. Does Maine believe it has adequate antibody testing capacity? And also, does it intend to start including contact tracing? Is that going to be happening in the future here?
Great. Thanks for those questions, Patrick. When we take those in reverse order, Patrick's first question is around contact tracing. And Patrick, in any outbreak scenario, we are always doing contact tracing. Now, with COVID-19, we have taken to doing contact tracing for single cases of COVID-19. And so that is something that has been a practice at Maine CDC since the very first second we had our first confirmed case. We have been conducting that contact tracing. And contact tracing is the process whereby our gumshoe epidemiologists, our disease detectives, touch base with every single person who we have a confirmed case on. We ask them everywhere they've been in the last 16 days, every person they've interacted with, and then we reach out to all of those people to put them on alert that they could be at risk for getting the disease. So Patrick, ever since our very first case, we have been preparing for and are now conducting intensive contact tracing across the state. But as we conduct more testing, it's invariable that we will have more cases. And thus, we are building out an additional force of individuals to conduct this contact tracing. Our first step has been to rehire folks who have recently retired from Maine CDC, and then look for others who are skilled in epidemiology to add to that force, because we know we're going to have more cases. So Patrick, I just want to be really clear. We have been doing intensive contact tracing from minute one and intend to continue to do so. Now, your former question was around antibody testing. There's been a lot of talk and discussion about the role of antibody testing and where it fits into where we are in the outbreak right now. Again, we're still in the middle of this. And so the best vaccine, the best way that we have right now to manage the risk of COVID-19 is through physical distancing. Right now, physical distancing is far superior to any other type of intervention out there. That being said, antibody testing does have the promise as well as the potential to be a valuable tool in our approach to COVID-19. It's one we're evaluating. It's one we're including in our plans as we continue to manage the outbreak. But having the potential to be useful is not a strategy. Right now, there are significant scientific questions. Perhaps many folks saw a really well-done article in the press yesterday about some of the limitations around antibody testing and some of the concerns at a national level about some of the tests that are already out there. So we're evaluating all the data, as is FDA. Right now, there are very few antibody tests that have been approved for use across the country. And some of the ones that have been approved for use don't really have the capacity to run the number of tests that we would need. They can do 1 per hour, which isn't really what we need to be looking at. So we're continuing to study antibody testing because we recognize the potential that it has, because it can help us determine who might have been exposed and thus who might already have antibodies. But at this stage, we're waiting for the FDA as well as the US CDC to provide a bit more clarity on which tests will actually make the cut. So thanks for those questions, Patrick. I'd like to turn back to see if Pat Callahan from News Center has joined us.
Dr. Shah, I think the third time's the charm. Thank you.
You bet.
I did want to ask you a couple of things. One, we're seeing nationally today that the largest increase in the number of cases is in rural states such as Iowa and Nebraska. So is that of particular concern to you as Maine as a rural state? Second, it's clear there's a lot of people who are worried about their livelihoods and they want to get back to work. And we saw the demonstration outside the Blaine House today asking the governor to lift the stay-at-home order. Yet in that crowd, we talked with one person who said, well, the governor shouldn't be curtailing our civil liberties based on a hunch. How do you respond to somebody like that?
Mm-hmm. So, Pat, your first question is about rural cases. And you are correct that just in the past 48 hours, 72 hours, nationwide, there has been a significant uptick in the number of cases detected in rural states and rural parts of urban states. You noted Iowa. I would also add, I saw some rapid data that came out of North Dakota indicating a large spike there as well. Some of it is driven by the fact that testing is now permeating to those parts of those states. But other parts of it, I think, are related to what are somewhat unique aspects of rural parts of the country. In some cases, rural parts of the country offer some degree of protection. They are, by nature, in some instances, already physically distanced. But other aspects of rural life can put folks at a higher risk. Folks who live in rural parts of the state, of any state, may have jobs that take them into contact with people. They may be frontline healthcare workers or work in forward-facing consumer settings. They may also have less access to healthcare just at baseline. So I am deeply concerned about the impact of COVID-19 on rural parts of Maine. For going back several weeks now, several months, we have made it a point not just to touch base and work with facilities in urban centers, but also in rural parts of the state through healthcare coalitions, through the medical associations, through groups like that, to make sure that they didn't have a false sense of security. And again, what we have seen is now cases in rural parts of the state. Over the weekend, we recorded the first case in Piscataquis County, which up until the weekend had no cases. So for those of you who are watching right now who live in a rural part of the state, even though there might be more cases in urban parts of the state, bear in mind that there are more people in those parts of the state as well. And so even if you happen to be in a rural part of the state, it's just as important for you to lead your life as if the virus was circulating around you, and try as much as possible to stick with the course and adhere to those physical distancing requirements. We are still very much in the middle of this. And what I hope doesn't happen is that we see a secondary bump in cases in rural parts of the state, because that would be a situation where healthcare providers may not have the same degree of resources. So for those of you in rural parts of the state, please take care. Now, Pat, you also mentioned some activity that's going on here in Augusta, and my message for those folks is to please try to stay safe. The virus is out there, and so please stay safe as anybody is out there. That's the same message I have for everybody in the state right now. Please stay safe while you're out there. So thank you very much, everyone. I appreciate all the questions. Thank you all for tuning in. I look forward to chatting tomorrow. Take care.